Let's record it. There we go. Skip the ad. And I can't get the volume higher. I know. I love her though. She's good. All right, so systole is what? Ventricular contraction, right? Diastole is ventricular relaxation for the most part, because remember our ventricles are the driving force of the cardiac cycle. All right, and keep that in mind too when we start to get into blood pressure. When you look at your two values for blood pressure, it's going to be, all right, systole and well, systolic and versus diastolic blood pressures here. Right? We feel comfortable with that? And seriously, if you don't, I'll explain it to you again. All right, area of high pressure, and it'll move into an area of lower pressure, okay? And wherever that pressure is greatest across the valves will cause those valves to be either opened or closed, because valves are one way. What's the purpose of the valves? That's right, prevent backflow, one-way direction of blood, okay? I hope it is, because you guys will know it. You will know it.
The cycle is initiated with a function of the SAO that stimulates the atrial to depolarize. This is represented by a preload on the ECG. Atrial contraction starts shortly after the preload begins and causes the pressure within the atrium to increase, forcing blood into the ventricles. Atrial contraction, however, only accounts for a fraction of ventricular flow, because at this point, the ventricles are already almost full with passive blood flow down the ventricles through open AV valves. As atrial contraction completes, atrial pressure begins to fall, reversing the pressure gradient across the AV valves, causing them to close. Closing of the AV valves produces the first breath sound, S1, and marks the beginning of systole. At this point, ventricular depolarization, represented by the QRS complex, is halfway through, and the ventricles start to contract, rapidly building up pressures squeeze onto ventricles. For a moment, however, the cerebellar valves remain closed, and the ventricles contract in a closed space. This phase is referred to as isovolumetric contraction. No blood is ejected, and ventricular volume is unchanged. Ventricular ejection starts when ventricular pressures exceed the pressures within the aorta and pulmonary artery. The aorta can pull valves open, and blood is ejected out of the ventricles. This is the rapid ejection phase. As ventricular repolarization, reflected by the T-wave begins, ventricular pressure starts to fall, and the force of ejection is reduced. When ventricular pressures drop below aortic and pulmonary pressures, the semilunar valves close, marking the end of systole and beginning of diastole. Closure of semilunar valve produces the second part sound, S2. The first part of diastole is, again, isovolumetric, as the ventricles relax with all valves closed. Ventricular pressure drops rapidly, but their volumes remain unchanged. Meanwhile, the atria are being filled with blood, and atrial pressures rise slowly. Ventricular flow starts when ventricular pressures drop below atrial pressures, causing the AV valve to open, allowing blood to flow down the ventricles passively. The atria contract to finish the filling phase, and the cycle repeats itself.
I think I like that video more and more every time I see it.
I don't like it.
I love it. I just don't know why. I just think she does a pretty good job and just in the short period of time. Again, now I've seen this video like 50 times, all right? But it's one of those things where you will, if you watch it enough times and really understand it and break it down, it will definitely help with your understanding of the material. Okay, so let's finish up chapter 19. I've had a lot of fun in chapter 19, but I'm ready to move on to circulation. So I want to finish up with cardiac output and then certain items that increase the contractility and what affects your cardiac output, your stroke volume, and whatnot. All right, so introduction to cardiac output. All right, I think we talked about this briefly last time, so I'll start here, and we'll go from that. Okay, first of all, this is one of the first equations that you need to know. You need to be familiar with this equation here. Cardiac output is going to be your heart rate times your stroke volume. Okay, just to review, stroke volume is the amount of blood that is ejected out of the ventricles. It should roughly be the same between the right and the left ventricle because the ventricles are supposed to be in balance. Okay, so when we talk about what actually cardiac output is, all right, it is the amount of blood that is pumped by a single ventricle in 1 minute. Okay, 1 minute. So therefore, it's going to have to do with volume, and we measure it in liters, and time. Okay, so it's going to be liters over minutes, all right, which will be 1 minute. Okay, so basically, cardiologists, folks that are physiologists that have to do with the cardiovascular system will use it to monitor the overall function or performance of the cardiovascular system. Okay, so this value will definitely increase when someone's exercising. And if you think about it, or if you look at the equation just from a purely mathematical standpoint, when you're more physically active, your heart rate increases. So just do the math. Your heart rate goes from 75 beats, all right, per minute to 100 beats. Okay, that's going to change, and I think the same values that we used last time. All right, that'll bring it up to 7 liters per minute. Okay, just from going to 100 beats per minute. Okay, so if any of these values, so basically what I tell folks, again, I'm not a great mathematician, all right, but I do understand how equations work and whatnot. If you increase either one of these values here, heart rate or stroke volume, you're going to increase cardiac output. Okay, if one remains unchanged and you decrease the other, then cardiac output will decrease. Okay, at least let's get that settled and cleared. Okay, because when we're going to now talk about what influences heart rate, what influences stroke volume. Okay, because if you're still unclear about what stroke volume is, no problem. We're going to talk about that. We're going to really talk about what happens here. Okay? All right. So think about this. As we're all sitting here, we talked about this last class, all right, when we're at rest, we need to be able to pump enough blood through our circulatory system to satisfy the needs of all of our tissues. Because otherwise, what will happen if we can't satisfy their metabolic needs? You could die eventually. Yeah, you're absolutely right. Absolutely right. You could die. You know, you'll start to undergo ischemia, especially for those tissues that require and need oxygen, like the myocardium. All right. But also think about all the tissues that rely on, all right, blood. Well, obviously blood, but like glucose, fatty acids, proteins, whatever. All right. So the heart has to supply that. All right. So this is where we were talking about last class, where I talked about the Gremlins movie and everything, and how folks that have smaller hearts, okay, we'll use kids, all right, their hearts are smaller, so therefore the volume, their stroke volume will be less, so their heart has to beat faster, okay, because the chamber's smaller, right? All right, our chambers can accommodate, let's just say, 140 milliliter volume of blood. All right, child's heart can't accommodate that, maybe 50 milliliters, okay? So in order to maintain that cardiac output, their heart's going to have to beat faster. Conversely, when we're dealing with folks that have larger hearts, those chambers will be bigger, all right? You'll see that in a lot of professional sports athletes, people that have to do a lot of endurance exercise, running, cross country. I don't even know the name of that one sport in which they do snow skiing with the rifle, which I think is really cool. Imagine having, do you know the name of that?
Never heard of it.
You never heard of that? Does anyone know what I'm talking about in the Winter Olympics? I watch goofy things in the Winter Olympics. I love curling. All right, I absolutely love curling. That's my thing. Yeah, I think I'll be an awesome sweeper. All right, but in this Olympics, in the Winter Olympics, they have this sport in which people cross-country ski. They race against each other. Then they have to stop somewhere, and they have a rifle on their back, and they have to hit these 5 targets. All right. If you think about it, you're going hard. Your heart's pumping out. Now you have to hold a rifle because you probably know what I'm talking about. It's not easy because you're breathing and the rifle's moving around, and you got to hit those targets and move on. Anyways, yeah, those folks have great endurance. Okay. So therefore, their heart is going to beat less. All right. All right. It won't be as fast. So again, there's that payoff there. So we could say larger hearts, you'll have a larger stroke volume, but a slower heart rate. Okay, because we're going to meet the tissue's needs there. All right. Cardiac reserve is basically what I was talking about last time. When you have to engage in activity of some sort. All right. So the equation that we had before, our cardiac output was 5.25 liters per minute. That's just at rest. Now you start working out and your heart rate goes up. And it goes up to 7 liters per minute. All right. So the difference between these two volumes, which is 1.75 liters, is going to be your cardiac reserve. That's it.
How do you get the stroke volume?
Well, I was just using the values from that previous page there. On average, the stroke volume is going to be 70 milliliters. That's just going to be on average for all of us. So every time the ventricle contracts, it's going to squirt out 70 milliliters. We'll talk about what can change that. But as we're all sitting here, it's pretty much the same for all of us. Okay.
Oh.
So, and then our average heartbeat, whatever, is 75. Okay. So using those same values, that's how I can determine what the cardiac reserve is. All right. So obviously, folks, that are going to be in better shape, all right, are going to be able to handle and have a larger cardiac reserve if need be. Okay. All right, now that leads me into this. We didn't talk about this. All right, so now we're going to talk about things that influence just the heart rate. So I'm going to write this down. Cardiac output equals HR times SV, stroke volume. Okay, so now we're going to talk about the things that influence that right there. Okay, so you can either do 2 things with your heart rate. You can speed it up, or you can slow it down. Okay, that's what we're going to deal with. So we're either going to increase it or decrease it. Obviously, if the stroke volume stays the same, if we increase our heart rate, what do we do to cardiac output? We increase it. If we decrease our heart rate, what do we do to our cardiac output? Decrease. Okay, good. We're all on the same page. So now we're going to talk about what causes that. So when we talk about chronotropic, all right, we're going to be dealing with our heart rate here, okay? We're going to affect these cells right here, the nodal cells. Where are they located? All right, in the sinoatrial node, and they're also located in the atrial ventricular node, the AV node, SA node, and the AV node, okay? So we're either going to affect just the cells in the SA node, or we're going to affect both the cells in the SA node and the AV node, okay? So what affects that? The autonomic nervous system. We talked about this way in the beginning of this chapter here, all right, with the parasympathetic and the sympathetic, and then hormones, okay? So basically, that's our communication system of our body, right? We have 2. You have the electrical communication, which is the nervous system, and then you've got the chemical communication system of your body, your hormone system, the endocrine system, okay? So both of those systems are going to play a role in changing our heart rate. So let's talk about the first category, positive. That means we're going to increase our heart rate, right? There's only, out of the autonomic nervous system, only one division increases the heart rate. And we know that from last semester, or excuse me, I keep saying that, from 210, okay? We learned that when you increase sympathetic stimulation, right, you're going to increase the heart rate. Okay, so now we're going to talk about, we learned that, but we didn't know why. Why does it do that? Okay, So it all starts off with norepinephrine. Norepinephrine is going to be the neurotransmitter that is going to be involved in this. Okay, so that sympathetic neuron is going to release its norepinephrine onto the nodal cell. Meanwhile, your adrenal glands, all right, specifically the medulla of the adrenal glands, is going to be pumping out epinephrine and norepinephrine. So now you got a lot of stuff getting poured onto these these nodal cells. Point being is, all right, the norepinephrine and the epinephrine are going to interact with the nodal cells, and it's going to increase their firing rate. That's the overall picture that we're going to see here. We're going to increase the firing rate of the nodal cells. How? Remember this? Secondary messenger system? This should look familiar from chapter 17. Okay? So here's what's going to happen. I'm going to stop there. I'm not going to write that word out. All right? So the norepinephrine is going to be released, and the epinephrine are going to be released or find their way into the synaptic cleft. Remember the synaptic cleft? That's that space in between the nerve, all right, and the actual target tissue. All right, in this case, it's the nodal cell, where there are these receptors there. Okay, and they're ligand receptors, which means it's like a lock and key. You just got to get the right key to activate those receptors. In this case, you need to know this, they are called beta-1 adrenergic receptors. Sometimes you'll see it B1 with the Greek nomenclature of B, which is this. Okay? B1 adrenergic receptors. And what they'll do is, and we already learned this cascade, so this should all be review. It'll activate the G protein. That G protein will then activate the adenylate cyclase enzyme that sits in the plasma membrane. That adenylate cyclase will break down ATP into cyclic AMP. And that cyclic AMP activates this enzyme, protein kinase. What is a kinase enzyme? It's an enzyme that likes to put phosphate onto things. So what do? We phosphorylate the calcium channels there. Basically, that's a fancy way of saying, hey, we open up a channel. So guess what? Calcium pours into the cell. Because remember, calcium is in higher concentration outside the nodal cells than inside the nodal cells. Okay? So calcium pours into the nodal cell. It's a positive ion. It pours into the nodal cell. So it's going to depolarize the nodal cell. You already know all that. I'm just here just to help to remind you about it. Yes, ma'am.
So the chronotropic agent, that would just be like something that increases your heart rate?
The positive chronotropic, yeah.
Exercise or something, or is it like a
It's going to, yeah, it's going to affect the heart rate only, not the stroke volume, but yes, yes.
But what is it exactly? Is it an activity that's increasing it, or?
Oh, I see what you're saying. It's not the stimulus. You're saying it's not a stimulus. It's going to be an actual. For here, it's a molecule. All right, it could be a hormone. It could be a specific molecule, something that's going to stimulate. We're going to actually look at some of them. I'm going to show you a whole bunch of examples. That's a great question. See, that's what this picture shows us. I'll zoom in on this. All right, this picture here. All right. Here, all right, so here's our sympathetic neuron, okay? So our action potential comes down. It's going to trigger, all right, the synaptic vesicles to release their neurotransmitter. In this case, it's norepinephrine. Meanwhile, at the same time, the adrenal medulla is going to be releasing epinephrine and norepinephrine, which are both neurotransmitters also, okay? So they're going to go into the blood, all right, travel here to the heart, all right? Eventually, all of these guys are going to pour into the synaptic cleft. Okay, and it's going to activate these beta-1 adrenergic receptors. And it's these beta-1 adrenergic receptors which will activate that G protein, because it's inactive. It's going to activate the G protein, which will then activate the adenylate cyclase enzyme to break down ATP into that cyclic AMP. And that cyclic AMP, all right, will then activate this protein kinase enzyme. Kinase phosphorylates things, puts phosphate onto something. So that's what it does. It's going to phosphorylate these calcium channels, because our end goal is to open up these calcium channels. We get calcium to flood into the cell, we depolarize the cell. The more channels we open up, the more calcium pours in, and we can depolarize the cells quicker. All right, that's our goal. Our end goal is to get these cells to fire. We're going to activate our conduction system, because remember, the nodal cells are found in the SA node and the AV nodes. Okay, so that's what we got to do. So how do we get these cells to depolarize? Right, we're going to let calcium pour in. So here's a couple things that will stimulate this. I'm going to go back. Well, I have to go back. I'll quickly go over this. All right, so here's a couple of our chronotropic agents that are going to affect the heart rate. Nicotine, cocaine, thyroid hormone, caffeine. I'm sure that a lot of us are on this. That's the caffeine I'm pointing to. At one class, I accidentally was saying, I'm sure a lot of us are on this, and I didn't move the mouse, and it was over cocaine. And the class was like, no, wait, what are you talking about? And then one class actually said, oh, I do a lot of this, and it was still on cocaine. I was like, oh, no, I mean caffeine. All right, but point being is these are going to be, and you can see right here, for example, nicotine. Okay, nicotine is going to stimulate the release of our neurotransmitter. Okay, so again, if we release more of the neurotransmitter into the synaptic cleft, we can activate more of these beta-1 adrenergic receptors. All right, it'll just wash through. Cocaine, it inhibits the reuptake, which means the norepinephrine, our neurotransmitter, is going to hang out in that cleft longer. So it's going to stimulate, again, those beta-adrenergic receptors. All right, you can see here, thyroid hormone is going to put more of these receptors in the plasma membrane. See, all of these things are going to help to contribute. Caffeine, this is great because it's going to allow cyclic AMP to hang out longer, okay, because we don't break it down. All right, so if it's staying out in the cytoplasm, in the cytosol, then we can activate more of the protein kinase enzymes. All right, so let me put into words what I just showed you here. Okay, so these are going to be, all right, some examples. So to kind of go back to what you're saying, Casey, yeah, there's a hormone there. All right, we have some chemicals there, caffeine all the time. Although I don't think caffeine works on me anymore, help keep me awake. You know, but some people do.
Try to switch
Yeah.
the
Yeah, maybe. I went. Has anyone here been to the Coca-Cola Museum? I asked them. Because I asked them on the tour. I'm like, did you guys really put cocaine? You guys have probably heard that, right? Yeah, and they wouldn't come and tell me if it was. They said there was things that we put in there that we shouldn't have, or whatever. And somehow they're really political about it. I'm like, that's what I was thinking. I'm like, because that was the rumor way back in the day. They used to put cocaine in Coke, and that's why the word Coke came from. I don't know. But anyways, I thought that was funny. All right, so again, you can see, all right, thyroid hormone is going to help upregulate or increase the number of our beta-1 adrenergic receptors. So then we can now then open up, we can then activate more G proteins in that case. All right, helps to decrease or inhibit the breakdown of cyclic AMP, so we have more of that floating around in the cytosol. All right, nicotine is going to stimulate the vesicular, the secretory vesicles to release that norepinephrine into the synaptic cleft. And then obviously cocaine is it's a reuptake inhibitor, okay? It's just going to prevent norepinephrine from being broken down or taken back up into the presynaptic neuron there and being packaged back up into the vesicles. So here are some of those examples. All right. They go what? Yes, absolutely. Okay. All right, so we talked about the positive. Let's talk about the negative. Okay. So we know with the positive, it's sympathetic. All right. So with negative, we're going to decrease our heart rate. So we're going to deal with the parasympathetic nervous system. Okay. So in this case, look, different neurotransmitter. Okay. In the autonomic nervous system, in the somatic nervous system, when we're dealing with a lot of those neurons there, we're dealing with acetylcholine, right? Parasympathetic is going to release the norepinephrine, but here with the parasympathetic, we're going to release acetylcholine. Okay, it's just another neurotransmitter in this case. And we're going to deal with a different type of receptor called muscarinic. Okay, but basically, it's potassium channels. Okay? So as you know, if we open up potassium channels, where is potassium in higher concentration? Outside the cell or inside the cell? Inside. So it's going to flow out, and it's going to make the inside of the cell more negative. What do we call that process? Well, hyperpolarization. We're going to hyperpolarize it. I mean, yeah, repolarization is part of it. I mean, well, when I say part of it, repolarization has to follow depolarization. In this case, we're going to hyperpolarize it. So we're going to go now take it even more negative. Oh yeah, it'll be like negative 95, negative 100. Yeah. Yep, exactly. I know what you're thinking. Yep. So that means now, if we're going to try to depolarize the cell, it's going to take longer to get to that threshold value. And as a result, we slow down our heart rate. Okay? Perfect example is the beta blocker drugs. Okay? So if we use beta blocker drugs, and you can use them for, well, the overall effect of beta blocker drugs is, one, if you're dealing with heart rate, it'll decrease the heart rate, but you can also use it to help manipulate blood pressure too. All right? But what happens is now our epinephrine and our norepinephrine cannot bind to those beta receptors. All right? And when that occurs, then we cannot activate that secondary messenger system. Oh, darn. As a result, all right, the parasympathetic nervous system is the predominant nervous system that's going to be affecting the heart rate. And what's going to happen? It's going to decrease the heart rate. Well, that is definitely good if you got high blood pressure. Right? You decrease that heart rate, you're going to be pumping less blood, all right, over a period of time out of the heart. And that will decrease the blood pressure. Has anyone heard that beta blocker drugs are bad for people with insulin dependence? Diabetics? There's a debate on that. It does influence insulin release from the pancreas, all right? But for the most part, I don't think, last I checked, there wasn't anything that would prevent. It's not contraindicated in life-saving incidents, you know, that you have to worry about killing the patient. Okay, so heart rate. All right, we're still talking about variables that are going to affect our heart rate here. All right, so that brings me to the autonomic reflexes here. All right, we've already talked about baroreceptors and chemoreceptors. We know their role, right? Baroreceptors sense the amount of pressure in the blood. All right, if you have high blood pressure, it's going to stimulate the baroreceptors, more pressure on the vessel walls. All right, chemoreceptors will tell us if you have high amounts of carbon dioxide, low amounts of oxygen. Right? So all of that is going to send messages, remember, to our cardiac center. We have the cardioacceleratory center, the cardiac inhibitory center, and the medulla oblongata. Okay, and that will stimulate changes and influence input and output of the sympathetic and the parasympathetic nervous systems. So if your blood pressure is high, we want to slow the heart down. We want to get it to produce, to decrease the cardiac output, or the stroke volume, I should say. So what do? We inhibit the sympathetic nervous system, and then we stimulate the parasympathetic nervous system until your blood pressure falls down. Okay? And vice versa. Okay? If your blood pressure starts to drop, okay, then what we do is we are going to inhibit the parasympathetic, and then we're going to stimulate the sympathetic. We talked about that before. All right? So we have the Bainbridge reflex, the atrial reflex, and this has to do with the amount of pressure on the atrial walls during filling. Okay? So if you keep filling, all right, the heart, the atria, too much, just like a water balloon, you risk popping the balloon. Okay? Damaging the balloon. Well, in this case, all right, with the atria, if we overfill them, then we risk damaging the atria. We don't want to do that. So we have these baroreceptors, all right, that are found in the atrial walls, and they're monitoring that venous return. Remember, the venous return is the amount of blood that's returning to the heart, okay, that's coming into the heart. Therefore, it's coming into the atria, all right? So what happens if the heart gets too much blood? It's going to signal, all right, the cardioacceleratory center, okay, to pump out that blood. So we're going to increase the heart rate. All right. And by doing that, we're going to stimulate the heart to beat faster, and that's going to increase the amount of blood that moves through the heart. And as a result of that, the atrial stretch decreases. Okay? Any questions at home? You guys are silent there. Good so far? Am I making sense? I hope. Okay. Okay. Cool. All right. So that's the atrial reflex. So that's going to be, all right, another thing that will influence your heart rate, the amount of pressure that is occurring on the heart wall there in the atria. Okay. So now, remember, going back to our equation, cardiac output, all right, is equal to heart rate, all right, times stroke volume. So now we talked about the first part. Now we're done with that. Now let's talk about the second part. Now we're going to figure out what's going to influence our stroke volume. How do we increase that? How do we decrease that? All right, so this is the second part of that equation that we're going to discuss. Okay, so let's redefine stroke volume. It's the amount of blood that's going to leave the heart in just one beat. Okay, so there's three things that are going to influence our stroke volume. Venous return, the amount of blood coming into the heart. All right, ionotropic agents, similar to ion, okay, ionotropic agents, think of contractility, okay? How can we make the cardiac muscle cells contract more effectively or less effectively? Okay, and then finally, afterload. What is outside the heart? What's in the systemic circulation or the pulmonary circulation? Okay? All right, so venous return, all right? The blood that comes into the heart should be roughly equal to the amount of blood that leaves the heart in a well-balanced heart. That's what we're looking for, okay? So if our stroke volume, all right, when I say it's roughly the same, it won't be exactly, but what I mean by that is, all right, if our stroke volume increases, then the venous return should also increase. Remember, like what comes up must come down, all right? What goes out must come in, right? So if the heart is going to be pumping out more blood, eventually more blood will be coming back to the heart, all right? So another way that we can look at it is end diastolic volume. You'll also refer to it as preload. All right, so perfect example, going back to that Bainbridge reflex there, right? If we're getting 50 milliliters of blood pouring into the atria there, okay, right? If we increase that, all right, that 50 milliliters of blood, say it's normal, and we increase that to 60 milliliters of blood, okay? When the atria contract, they're going to pump that 60 milliliters of blood into the ventricles. So then when the ventricles contract, they're going to pump out that difference in blood, okay? So if we increase the venous return, because it's going to put more blood into the ventricles when the atria contract, then we're going to increase our stroke volume. That's what this means, directly related to stroke volume. If you increase stroke volume, you're going to increase venous return. All right? Oh, before I forget, I should have shown you this at the beginning of this. Shame on me. This is a really, really good slide here. All right? Factors affecting cardiac output. All right, this is, if you're having trouble, like obviously you want to know details hopefully as much as I do. But if you can understand everything, this is figure 1926. All right, if you can understand, all right, this figure here, then you're going to understand pretty much what I've been talking about in class today. Okay, so going over what I just said here about the chronotropic agents here. All right, remember cardiac output, all right, is going to be heart rate times stroke volume. Okay. So we just went over this. The positive agents are going to increase your heart rate. Okay. Nicotine, thyroid hormone, all right, cocaine, caffeine, all right. Negative agents are going to decrease that. Okay. Stimulation of the parasympathetic nervous system. all right, will then decrease the heart rate. Now we're going to talk about this. So when we talk about venous return, this is the amount of blood that's going to return to the heart. It's going to cause that atrial stretch there, okay? Which means if I increase the venous return, I will increase the stroke volume. If I decrease the venous return, I will decrease the stroke volume. That's what this means. It's directly correlated with. What you do to one, you will do to the other. Okay? Cool with that? All right. I should have showed you that first. I like that one. Where am I? Okay. So again, a couple terms just to keep in mind. Preload. All right. That's what we'll call, all right, that venous return volume in the atria. Okay. And that preload will then move into the ventricles when the atria contract, right? And that helps to determine our end diastolic volume there. Okay? All right, this next principle or topic that I'm going to talk about, this is very important, this Starling Law. All right, this is still with venous return. Okay? So, if we increase our venous return, meaning more blood comes to the atria, and then it pumps that extra blood into the ventricles, all right, that's going to increase our end diastolic volume, because remember, end diastolic volume is the amount or the volume of blood in the ventricles after the atria have contracted, all right, and the atrioventricular valves are closed and the semilunar valves are closed, okay? Isovolumetric contraction, that's the amount of blood that's in there. So if we pump more blood into the ventricles than normal, we're going to stretch the heart wall. Right? That's not a bad thing, because what does that do? That increases our overlap between the thick and thin filaments. Okay? When you get more overlap, more cross-bridge formation, we've said this before, all right, with skeletal muscle, with cardiac muscle, when you get more cross-bridge formations, you're going to get a much more powerful, I hate to use the word powerful, but effective contraction, right? So if you have more cross-bridge formation in your skeletal muscle, if you're doing a certain type of exercise, you're going to get a stronger response from that. Same thing here with the heart. We get more overlap between our thick and thin filaments, then we'll get a more forceful contraction, which means we're going to eject more blood out of that heart. Okay? That's what the Starling Law represents. Okay? So increase the volume in the ventricle, increase the pressure on the ventricular walls. That's going to increase the overlap or optimize the overlap between the thick and thin filaments. So when the contraction occurs, you're going to get a more forceful contraction, and you're going to eject that increased volume of blood. So that means our stroke volume increases. Okay?
And why does this happen? Like the condition?
Well, yeah, I mean, if we're increasing, if we're what?
Like exercising?
Well, that's perfect. Did you read the slide ahead of me? You're going into the, no, this is good. You're leading, that's a leading question. I emailed her and told her to ask me this question at this exact moment. So it'll bring me right into there. This is perfect.
Like you read some of this and you're like, well, what did it?
Right. I'm going to get there. I'm going to get there.
Cool story, but like, why?
Well, this is and it's perfect because, and again, I know a lot of the examples here I'll use with exercise here, okay? But this is what will happen because, right, in the well-trained heart, okay, in these awesome endurance athletes, these marathon runners, okay, their heart rate is low. Their resting heart rate is low, right? Because one, they're at rest and their tissues don't need, all that blood until they're exercising. So what will happen is when the heart rate decreases, you're giving the heart more time to fill. And when you're giving it more time to fill, all right, you're going to increase, all right, the volume. Do I have it? I don't have that word up there, all right? You'll increase the volume. So the ventricles will have a little bit longer time, all right, to fill up, all right? That passive filling will be longer. Our venous return is increased because we have a much more effective cardiovascular system. So the atria will pump in more, all right, blood during their contraction period, okay? And what will happen now is the heart will eject that increased volume. Now, when we're exercising, all right, what do you do? Like running, for example. Remember when we talked, no, well, or riding a bike. Let's say riding a bike. Okay, you're exercising. And we talked about it in lab on the first day. Veins have valves. Okay, so basically, the valves prevent backflow, much like the heart. Okay, but what helps to move the blood through those veins is when your muscles contract and relax, and they act as a pump. And so they'll press on the blood, and it'll squirt the blood up. All right, because it can't go down because there's valves there, and it goes only in one direction. It goes up, and then the muscles will relax, and then more blood moves into the area that the blood was prior, and then the muscles will squeeze again and shoot it up. Okay, so obviously when you're exercising, your muscles are contracting and relaxing much more. So it's going to pump the blood through the venous system more, which will then eventually get more of that blood back to the heart. It increases, all right, your venous return here, all right, because the muscles are squeezing on those veins and squirting it more towards the heart, all right? At the same time, like I said, we have a slower heart rate, so we're giving our heart more time to fill. There you go. And so now we can see, all right, how we're getting our stroke volume to be a little bit more because we're giving the heart more time to fill, but at the same time, the venous return is increased, and then that puts more stretch on the muscle wall, creating that overlapping and then a much more forceful contraction. Okay, so that's venous return. So what happens when you slice your radial artery? All right, you hemorrhage, you start to lose blood. Okay, so now your venous return is going to decrease. All right, but the heart responds by increasing the heart rate because the sympathetic nervous system is stimulated. One of the first things that will occur, your heart rate will increase initially, right, during a hemorrhage when you are losing blood. Okay, so how do we decrease our venous return? Well, one, we can decrease the blood volume, right, cut open an artery, or we can increase the heart rate, give the heart less time to fill. All right, when that occurs, we are decreasing our end diastolic volume or decreasing our preload. And so if we're having less volume in there via this Starling Law, all right, we will not have as much stretch on the heart wall. We won't have as much overlap between the thick and thin filaments, so the heart will contract as forcefully. So you will decrease or have a smaller stroke volume. Okay? So was it last? Yeah, it was last class. We talked about the balanced ventricular output, how the right ventricle and the left ventricle roughly put out the same amount of volume of blood. All right, the stroke volumes should be, all right, the same. And that has to do with, all right, even though the left side has more blood to pump up, excuse me, not more blood to pump out, it's got to pump blood out to the systemic circulation. And the right side is just dealing with the pulmonary circulation. All right, so even though, all right, one side is it can receive increased volume of blood, especially when you're exercising, all right, the left side might have to forcefully contract a little bit harder than the right side, right? And that's due to that Starling Law, which will then inadvertently give the other side of the heart more time to fill. So then it can return that to the systemic or the pulmonary circulation, and then it will eventually balance itself out. All right? It's almost like a compensation, but basically that ventricular output, that balanced ventricular output, has to pretty much do with the Starling Law. I was going to try to circle it, but it's in two different places. I feel bad for you folks because looking at my slides, I just mark them all up. It's distracting, I apologize. I like to emphasize certain things. Okay, so that's venous return. Let's jump down to this slide here. All right, so all that, all right, is one of the factors that's going to influence the stroke volume. All right, all that we just talked about. All right. Let's talk about ionotropic. Again, ionotropic agents are going to affect the stroke volume. How forcibly, all right, the heart contracts. Right. So then, if we're going to deal with how forcibly a heart contracts, we're going to deal with cardiac muscle cells because they're the machinery of contraction for the heart. So we've got to figure out a way, okay, how can we affect how these cardiac muscle cells can contract? Well, guess what? It's right here. Calcium. Calcium's the key, okay? And there's two places that we learned about where calcium is. All right, when we're dealing with cardiac muscle cells, it's either in the sarcoplasmic reticulum or it's outside of the cell itself. Okay, so those two places. But what we know is we need calcium. The more calcium we have released on the cell, the more cross bridges we can form. Okay, so there's a direct correlation there. More calcium, more cross bridges, more contractility. Okay. So calcium is king. It is very important. So we have a direct correlation or direct relationship between, all right, the amount of calcium and the number of cross bridges. Because the more cross bridges that we get to form, all right, the more forceful a contraction we can have. Okay? See, it's always easier to have 10 people pulling on a rope than one person pulling on a rope. Okay? So when we talk about positive ionotropic agents, they're going to increase calcium's availability. All right, and it's the same thing. We saw what happened there before when we were talking about the chronotropic agents. Okay? So we'll see stimulation of the beta-1 adrenergic receptors, and we know that story there, okay, and how that affects, right, calcium inflow. Because it eventually will open up those calcium gates on the plasma membrane of the cardiac cell, and it'll also help to increase, all right, the release of calcium from the sarcoplasmic reticulum. Okay, think of the sarcoplasmic reticulum, all right, as our reservoir, our storage site for calcium. All right, very popular drug, digitalis. Okay, it affects, all right, calcium inflow into the cardiac cells. So if somebody has a really slow heart rate and you need to get it up, like when I say slow, like 20, 30 beats a minute, you know, and they're not an awesome athlete, you know, they're sickly, all right, then digitalis is a good drug, okay? The negative ionotropic agents are obviously going to do the opposite. They're going to decrease the availability of calcium. If we decrease calcium's availability, we will decrease contractility, okay? So therefore, if we have less calcium being released from the sarcoplasmic reticulum, less calcium entering into the cell, we'll have fewer cross bridges, right, being formed. Okay? We see this quite often with electrolyte imbalances. Increased potassium is going to increase the membrane potential's negativity. Okay? Hydrogen, remember that? Hydrogen concentration, remember pH values and whatnot? Acids versus bases. Right? Same thing, hydrogen, well, I won't get into it, but pH can cause denaturation or destruction of proteins. That's the problem. What are proteins? Proteins are our channels. Okay? Those are transport proteins. Right? That could be an issue. Right? So channel blocking drugs are great for blood pressure. You decrease the contractility or the heart rate. All right? But not because of let me rephrase that. You'll decrease the stroke volume, all right, not the heart rate, the stroke volume. All right, finally, the last variable to influence stroke volume is afterload. What's outside the heart? The systemic circulation or the pulmonary circulation, all right? Basically, the arteries, okay? So if you think about it, when the heart is pumping, it's got to overcome partially the resistance of the blood that's outside of it, okay? So if we increase the resistance, then we increase the afterload, okay? So think of the afterload as the resistance outside of the heart, all right, due to the arteries there and the blood that's being injected out into that circulatory system out there, Okay? Because, remember, we already know, all right, if the ventricles cannot overcome the arterial pressure in the aorta or in the pulmonary trunk, the semilunar valves can't open. All right, so we have to be able to exceed that. An example is atherosclerosing, plaque buildup. Okay? What that does is it increases the resistance to blood flow. And when we increase the resistance, I'm jumping ahead. If it increases the resistance, it's harder to push that blood out of the heart. If we vasoconstrict all the arteries in the systemic circulation, we increase resistance. Okay? So it makes it much more difficult. So we make the lumen of those blood vessels smaller. We increase the resistance to that. We'll talk more about that. All right, lumen size versus resistance versus blood flow. Okay, but keep in mind, if we increase the amount of resistance out in the circulation, we're going to increase our afterload. Okay, and that is going to decrease our stroke volume because we can't push as much blood out of the heart. All right, so that's what this picture here is showing us. All right, the role here of stroke volume when we're talking about end diastolic volume, stroke volume, and end systolic volume. So with our venous return here, all right, also known as our preload, as we increase the venous return, we're going to increase our preload as we move blood down here into the ventricles. All right, let's see if I got it. All right, our afterload is going to be the resistance to the blood flow outside of the heart, so in the aorta, all right, and the pulmonary trunk. And then our ionotropic agents are going to show the forcible contractility of the heart. Okay, so here's our end diastolic volume. That's the volume of blood in the ventricles prior to the ventricles contracting and ejecting the blood out of the heart. And then what's left over is the end systolic volume. Keep in mind this equation here. End diastolic volume minus stroke volume is equal to the end systolic volume. An easy way I like to do stroke volume so stroke volume is end diastolic volume minus end systolic volume. Okay? And then you can just move that stuff, when I say move that stuff around, move these values around to figure out, plug and play and see. All right, you can see end diastolic volume is basically just the difference, or excuse me, the end systolic volume is just the difference between the end diastolic volume and the stroke volume. So basically these slides here, all right, are just what we just talked about here. Okay, so when we're talking about venous return, I'll walk you through it real quick. All right, if we increase our venous return here, we're going to increase the stretch on the arterial, or excuse me, on the atrial walls. Okay, we're going to invoke, all right, Starling Law, increase our overlap between our thick and thin filaments. All right, and they will contract and cause a larger volume of blood to enter into the ventricles here. And then when those ventricles, the same thing will happen. The ventricles then will have a greater amount of stretch. Okay, Starling Law, then that will cause a larger amount to be ejected, all right, as our stroke volume. Okay, so increase stroke volume, we increase our venous return. If we decrease our venous return, we decrease our stroke volume. Less stretch, fewer cross bridges. Okay, keep that in mind. All right, ionotropic agents, tough to see on this one. All right, this is basically the contractility of the heart. All right, so we're going to talk about the positive ionotropic. Right, the sympathetic nervous system, all right, is going to increase the contractility of the heart by increasing calcium flow into the cardiac cells, thereby increasing cross bridge formation, all right, thereby getting a much more forceful contraction. And vice versa, parasympathetic stimulation is going to block, all right, the increase of calcium going into the cardiac tissue, all right, that will decrease the contractility of the heart. All that will have an effect on stroke volume. Okay, so positive ionotropic agents will increase stroke volume. Negative ionotropic agents will decrease the stroke volume. And then we got afterload. All right, afterload is going to be the resistance outside of the heart in the arterial system. So if you increase the resistance, you'll increase the afterload, and you will decrease the stroke volume. If we decrease the afterload, therefore we decrease the resistance, we'll increase the stroke volume. Questions about that? The last 10 slides in this chapter are heavily physiology related, big time. I know. This is the stuff that I like though. Okay, so just a quick review, check it out. All right, cardiac output, all right, is going to be influenced by heart rate and stroke volume. That's that equation, CO equals HR, okay, times SB. All right. So when we're talking about the heart rate, we're going to deal with our chronotropic agents here. All right. So we're going to influence the SA node and the AB node. All right. So we're going to either increase their firing rate, which will increase the heart rate, or we're going to decrease the firing rate or alter the amount of delay. Make it longer. So that'll decrease the heart rate. All right, then stroke volume, think of it here. What is going on with the heart wall, the myocardium? All right, if we're increasing the venous return, the amount of blood volume that is returning to the heart, right, then we'll increase the amount of stretch on the myocardium, which will then increase the amount of blood that's getting ejected out of the heart through the stroke volume. Has to do with cross bridge formation. The more stretch, the more cross bridges we get, all right, the more forceful the contraction, the larger the stroke volume. All right, and then afterload, that's our resistance, okay? So if you increase the afterload, you decrease the stroke volume. It's a lot, I know. I thought I would move through this faster. But that's all right, though. I know. That was only a couple slides. So when you look here, that's why this is really important when you look at this, okay? So this part, I think, is the easier part, the chronotropic agents, all right? The positive increase heart rate, the negative decrease. So when we get to venous return, ionotropic, and the afterload, all right? But keep in mind, venous return, you increase venous return, you will increase stroke volume. If you decrease venous return, all right, you will decrease stroke volume. Afterload, it's an inverse relationship. You remember what inverse means, right? One goes up, the other goes down, okay? So with afterload, which is resistance in the arteries, okay? So if you increase the resistance, you will decrease the stroke volume, and vice versa, okay? If you decrease the resistance, you'll increase the stroke volume. All right, but just keep in mind that these heart rate times stroke volume gives us cardiac output. That equation, it says a lot, and now you know. And knowing's half the battle. Does anyone know what that's from? G.I. Joe? Hello? Oh. It was a cartoon that came out in the 80s. I was severely addicted to it, and that's all right. I'm comfortable with talking about my addiction. All right, I'm going to stop this video. We're going to go into the other part, all right, of the chapter. I just want to stop